Welcome everyone to the what used to be weekly, now bi-weekly or every monthly ArMA's COVID-19 virtual town hall. I'd like to thank everyone for joining us this evening, for those that are returning as well as new individuals participating tonight. A little bit of housekeeping before we get started. This is a professional environment. We ask that everyone remain respectful towards all participants. The webinar is being recorded and will be published for others to view at a later date on ArMA's YouTube channel. You can see and hear the panelists and moderators, but we cannot see or hear you. The webinar is best accessed through your computer utilizing the functions within Zoom. We ask that any questions, comments are fine in the chat, but if you have any specific questions that you would like to ask the panelists tonight, please utilize the Q&A function. And then its best viewing option is to fit the Zoom to your window. Tonight's moderators is Megan McCabe, ArMA's Deputy Director of Government Relations, as well as myself, Damian Johnson, ArMA's Director of Communications. Our guest panelist tonight is Manendra Bhugra. She's CCA Manager, Learning and Development. Jay Sandys, the Vice President of Organizational Development at CCA. Dr. Ross Goldberg, ArMA's current President. And Juliana Stanley, ArMA's Director of Practice Support. At this time, I'm going to go ahead and pass it on to Dr. Goldberg for a quick update from ArMA.
Thanks, Damian. Good evening, everyone. I hope you're all doing well. Obviously, we are still in the midst of this pandemic, but it seems to be hopefully going in the right direction, keeping a cautious, optimistic view on things. Your team continues to be out there every which way we can be, and appreciate everything that you're doing. I'm really excited for this town hall tonight and look forward to hearing what our guest panelists have to say, because I think this is really an important topic that we need to discuss. And so I'm going to stop talking and let the important people talk. So I'm going to hand it over to them right now. Thank you again for being here. Jay Manendra, it's all yours.
Great. Thanks a lot. Let me just introduce myself first, and then I'll have Manendra introduce herself, and then we can get going with the presentation. My name is Dr. Jay Sandys. I'm a clinical social worker by training. I'm the Vice President of Organizational Development at CCA, that's Corporate Counseling Associates. We're an employee assistance program and workplace consulting firm. I'm going to tell you a little bit more about that in a few minutes. We're really happy and excited about this program, so excited to dive into it. Manendra, do you want to just introduce yourself as well?
Absolutely. Welcome, everyone. Thank you so much for including us in today's panel. As Jay mentioned, my name is Manendra Bhugra. I co-lead consulting with Jay. I'm also the Manager of Learning and Development. So part of what we're going to be speaking about today is some of the training that will be coming for any of our volunteers as part of this virtual Doctor's Lounge. And I'll talk a little bit about that later on.
Great. Thank you. Damian, you want to move to the next slide, please? So here's just a quick outline. We're going to, our part of the presentation is going to be about 20 minutes. And then we're going to have time, of course, for questions. We really encourage you to ask them in the Q&A section, because we really want to engage you and talk to you about the program. So we'll do a brief intro to Corporate Counseling Associates. Then I'm going to talk about some statistics I pulled, really about physician distress, and really highlighting some of the issues that are being faced, especially now with COVID. I focus a little more on burnout, because that's a really prevalent one and a real problem, and it really relates to all the other distress and issues that are coming up. Some of the barriers to seeking help, solutions, of course. This one, the peer assistance program I'm going to talk to you about, the virtual Doctor's Lounge, is a peer assistance program, so we consider it one of the solutions. I'll give you an overview of the program. And in a way, one of the reasons we want to do this is we want volunteers, such as yourselves. So that's what we're going to try to get you to come on and ask any questions you might have, and come on board with us and provide the service. Okay, move on to the next one, please. So just a quick breakdown of CCA. We've been in business for over 35 years. We have a really large employee assistance program, and we cover over 500,000 members at 250 different types of client organizations. we have a lot of hospitals and healthcare institutions amongst a whole bunch of other industries. So EAP is a big part of our business. We also do a lot of learning and development, consulting, executive coaching, crisis response. The virtual doctor's lounge is really, in a way, it's an offshoot mostly of the EAP platform that we have. So that's really the capability it's using. But also Manendra is part of the learning and development team. So there's a big training component as well, because we're training all the peer coaches. And by the way, peer coach is purposeful because, and I'll say this again, this is non-professional coaching. We're not using the word counseling or therapy or anything like that. It's strictly non-professional support for your fellow physicians who may have some distress and want someone to talk to. And again, just a little bit at CCA, we have been doing a lot of trainings lately around mental health in the workplace, diversity, equity, and inclusion, leadership, management skills development, all that kind of stuff like that. So we have a lot of expertise training people and providing support as well. Okay, moving on. Damien? Okay, so here's, I pulled a lot of these stats just recently, and actually at the end I have a list of all the references if you care to look up some of the articles. But what I found was 44% of physicians experience symptoms of burnout. Actually, when I wrote that, I was like, wait, let me really look into this more at any point in their career. And actually the answer is when surveyed, at any point during a national survey or different times they've been surveyed, we're getting numbers around that 44%. Almost half of physicians feel that they're burned out when they're surveyed. That's a pretty big number. That's pretty significant. In a way, it speaks to why we need a program like this peer assistance. And I'm going to talk to you a little bit more about burnout as well in a few slides. 28% of medical residents suffer from depression. That's a big number. The research I read on this was that those residents didn't have any higher than normal levels of depression, which we expect to be around 7% of the population in the U.S. So 28% is pretty high, and it really speaks to how stressful it is to be a physician and to be a resident in particular. Approximately 400 American physicians commit suicide each year. Again, a big number, out of whack with the general population in terms of how many physicians there are. Concerning, obviously. And one of the reasons is that physicians avoid seeking professional mental health assistance. And I'm going to talk a lot about why that is. I'm sure you all know that already, what some of those reasons are, but that's a big part of the problem. And again, speaks to why we want to do a peer program, an informal peer program, rather than professional mental health services. About 12% of physicians have a substance use disorder. That's actually pretty much on par with the general population. But that research was a little bit old. I think it's about 20 years old. Something more recently showed that with alcohol in particular, 12.9% of male physicians and 21.9, almost 22% of female physicians have an alcohol abuse or dependence disorder. So that's pretty significant number. That's pretty concerning. Again, speaks to the need for some intervention here. Okay, moving on to the next slide. So now I'm just going to talk a little bit in the next few slides about burnout. It's a work-related condition, so obviously related to work, and it really, you can tell that it exists because you have emotional exhaustion, depersonalization, so you feel detached from yourself or from your identity, and a reduced sense of personal accomplishment, so ultimately feeling devalued or undervalued, or that you can't have an impact. Okay, next slide.
Jay, can I just jump in there for a quick second?
Please.
So I want to just kind of relate this a little bit, Damien, if you don't mind going just back one slide quickly, is that, if we put this in a little bit in the context of COVID, what we've been hearing from some of the physicians that we've been speaking with and other healthcare professionals is this is really draining, and I'm sure all of you can kind of speak to this as well from your own personal experiences, but just the nature of what you're experiencing and what you're seeing, it's challenging everything that you know as a physician. And that, like, when you think about all of these elements, right now at this point in time, everyone is a little bit primed to be burned out. So if they were starting to feel burned out before all of this started to happen, the current circumstances and what people are experiencing and the nature of the illness itself is probably contributing to a lot of this at this point.
Yes, thank you. Okay, good. So what's the impact of burnout? And again, this all comes from the research. So they really have seen a correlation with lower quality care, medical errors, longer patient recovery times, lower patient satisfaction, and just an overall negative work environment. And just to be clear, I'll get to it in the next slide, but we're not saying that it's physicians' fault that this is happening. It's really the environment. It's very clearly the environment. But nonetheless, physicians absolutely are being impacted. And these are some of the ways that it plays out in terms of the effect. Okay, moving on to the next slide. So here's some impact on health. So it's associated with substance abuse, depression, suicidal ideation, car accidents. So I guess you can see that being really tired or something, and lack of self-care. These are all related, right? So that's why I really focused on burnout. Before we were talking about suicide, depression, substance abuse, but they're all related to burnout too. Mm-hmm. So that's kind of the main thing that brings them all together. And again, something we really want to address with this program.
And in general, I think this is an ongoing challenge for a lot of physicians. But when we think about a little bit about what's happening in the current state of affairs, this is one of the very few times in history where you are directly experiencing something and treating patients to deal with the same thing. So that those fear elements, and I know Jay's going to talk a little bit more about this down later on in the presentation, but think about what is it that you're like currently doing to take care of your own self? What are you seeing your colleagues doing to take care of themselves? And probably the truth of the matter is very little, just because doesn't feel like there's time to do that. And so when you have that perpetual sense of overwhelmed stress, it's going to take a toll on your mental health and mental well-being. Thank you.
Next slide. Okay, so here's what I was saying before. What are the causes of physician burnout? It's all the stuff you guys know, right? This is what you're seeing every day with, when you're depending on what your work is. But high workload, complex patient population, that combined with short visit times, especially, short visit time may be fine if it's a healthy patient, but a complex patient, you're running into trouble with that. Administrative or clerical work, lack of communication with leadership. So leadership at the hospital or a clinic or wherever you're working, poor work-life balance, a high level of student debt. So if you've been in the work, if you've been working for a long time, that may not impact you anymore, but that's actually a big stressor I saw in the literature, especially when you get started. You really have to, pay that down. So that can be a big source of stress as well. And then some of the trauma following medical error or poor patient outcome. And again, all of this stuff is happening even more, right? Because of COVID. So it happened anyway, but now high workload, complex patient population, and then medical errors or even no error, but a poor patient outcome. What's the impact on a physician when that happens? That leads to burnout. That leads to depression, anxiety, substance abuse, or just overall distress. Okay, next slide. So we've done a number of trainings, Manendra a lot more than I, around COVID, about stress management and so on. So I pulled some of this, but from those trainings, and really customized it to stuff we've been hearing and what we've read about what's happening with physicians. We also did a lot of work with nurses, so some of the stuff was the same for them. But lack of PPEs and supplies, extended shifts because there's so many patients in the hospital. Because of the crisis situation, often physicians find they're separated from their usual colleagues, or they're working in an area where they don't feel like they have expertise. Sometimes there's standards of care are lowered, and there may be some ethical challenges as far as that goes. Fear of getting the virus yourself, or maybe the number one concern, infecting family or friends. So that's a big concern I've heard many times. So being placed in position with limited training. So again, I actually was doing some work with a physician who was on the ICU, but didn't have training for that. He was a surgeon, but he did all right, but he didn't really, that wasn't his expertise. So felt a little bit out of his depth with it. I think that's a common thing.
Right.
Witnessing the death of patients or how quickly they may decompensate.
And I think a few other things that we've heard in some of the workshops that we had run with healthcare professionals was like the length of time that someone's in the ICU, where you normally might have seen a patient just for a few days there. And you can obviously all speak to this better than I can, but in relationship to the length of time that they're there and not necessarily always seeing a patient getting better, they might be deteriorating in ways that you are completely unexpected. The fact that how one patient responds versus another patient responds, and then constantly changing protocols, feeling like you're walking in and all of a sudden it's like, wait, that's not what we were doing yesterday when I was here. And now you've got to relearn and reapproach every day. So there's never any routines that are being built. And that loss of routine is actually a huge factor in, how you approach your day and how you take care of yourself as well through a lot of these things.
Great. Thanks. Next slide, please. Okay. So here's some of the barriers, and this is stuff I've been hearing for years. We in the EAP world, because we work with lots of healthcare systems and different types of healthcare institutions, we know that physicians very rarely will use our service. It's not very common. The only way to get them to use a service is some sort of specialty program. So we already know about a lot of this stuff, and we've seen it in reality. One of the big concerns, of course, is confidentiality, and there's a lot of stuff around that is really, to me, is really related to confidentiality. So concern that it may impact your medical licensure. Again, that's kind of related to confidentiality as well. Here I'm citing a 2014 survey that found that 40% of physicians would be reluctant to seek help for a mental health issue that they had, or if they were to have one, because of those licensure concerns. And actually that's made worse in some states, because some states ask, some of the medical licensing boards will ask for a history of mental health issues. So they're asking about conditions. Have you ever had depression or ever suffered from depression or something like that, versus are you currently impaired? Are you currently abusing substances? Are you currently, too impaired to work, something like that. And in those states that ask the questions about history, there's even lower use of mental health or other help-seeking behavior because of that concern. Another big factor in this, and I'm sure you guys are aware of this because it's just it's so common in all medical environments, and actually not just in medicine, but in really the American workplace, mental health is stigmatized. So help-seeking behavior is stigmatized. We're hoping, I was just talking to Manendra about this, we're seeing maybe that's changing, but it's got a little ways to go. And I think especially in medicine, it's got a ways to go. There's distress happening there that's not being addressed. And one of the other things that I've seen and I've read about in some of the research I was doing is that physicians really internalize that distress and really recognize it and feel like it's part of their professional identity. That to be distressed, it's like you see it even in the media portrayal of physicians. It's like it's hard charging. They're under stress. It's really it's something that is really ingrained in terms of medical practice, and it's something that leads people to be martyrs and to burn out at such high rates and to have such high levels of suicide risk and other concerns because they're really not taking care of it. So. Anyway, moving on. Next slide, please. So here's a few solutions. Some of them really nothing to do with us, but I just wanted to list them because I thought they were pretty interesting. A lot of it is organizational solutions. So adequate support staff who are well trained, flexible work arrangements, and lots of other organizational solutions. I didn't want to list all of them here. For state medical boards, that they ask about current impairment and not about mental health condition. Pretty easy one there. create a healthy professional culture through education and stigma reduction. Okay, easier said than done, but that's actually part of what we think this program will do. Because it's a peer program, we'll be working with hopefully with many of you as peer coaches, and you can get the word out, and you can sort of get on board with this. And then anyone who uses the service also is in an informal way is getting connected to some help or to a colleague who will listen. We're easing them into it. And if people who are really in distress, we can then maybe more easily get connected to professional assistance, again, as needed. So that's the advantage of a peer assistance program. It's informal, it's non-professional. And so hopefully we'll lower the stigma and some of the concerns around licensing. Okay, next slide. So that's the whole intro. Now I'm going to talk a little bit more about the Virtual Doctors Lounge specifically. It was created by ArMA and CCA. So it's really sponsored by ArMA, ADHS, and AHCCCS. So those organizations together engaged us to create the program and really to oversee and manage it. It's a program that's peer assistance for all Arizona physicians, including residents. So we're not going to have residents be peer coaches, but they will be included in terms of accessing the service if they need it. Again, it's informal, confidential, peer-led. All the peer coaches will be licensed physicians. Okay, next slide. So just a quick, I'm gonna have a few slides that are gonna go over, it's kind of summarizing what the program is. So CCA, one of the advantages of CCA is we have many licensed mental health professionals, clinical social workers like myself and Manendra. We also have some psychologists and other licensed mental health professionals. So we will train all the peer coaches, and Manendra can really speak to that to this. So go ahead, we can go over some of the bullets here.
Absolutely. So in terms of what we're going to cover in the training is, one, we're going to really want to equip any of the peer coaches to feel confident in supporting their colleagues. So again, this is one of those things, it's like, I think Juliana, you had the best description. If you were to walk into the doctor's lounge in the hospital and reach out and say, you know, it's been a really tough day. So the idea here is that we're translating that into a virtual setting. And so as a result of that, sometimes, you know, it's very easy to get pulled into giving advice to a colleague, to really want to answer or help them deal with whatever distress that they're experiencing in that moment. And oftentimes that's in a very practical way. What we're asking here is that we switch that and become more of a listening ear, which is also an incredibly practical and important support to any of your colleagues that are there. But the goal here is that you're not going to necessarily solve the person's problems in that moment, but you're there so that they have that listening ear. And the challenge here is sometimes, how do we turn off that one side of our brain where we're listening to solve a problem versus listening to just be of a support to somebody. And so through this training, and there's going to be different components. The way we have it set up right now is that it's going to be 3 different sessions. Each of the sessions are going to run about 2.5 hours. The dates we'll share with you in just a few moments if you are interested in going through these. But each of those is going to focus in on what are the parameters, what are the expectations in terms of what is your role as a peer coach. We really want to speak about, how do you engage? How do you build that rapport? How do you provide that support in the moment? The bonus here is your colleague is calling because they need help and they need someone to talk to, and they feel like the only person that can hear and understand what they're going through is someone else who's in the same role, which is another physician. Now, there are going to be, in some cases, you might get to a point where they might ask you, like, what are you doing? How are you managing? So we want to talk a little bit about what we call selective disclosure. How much do you share? How much do you engage around, you know, have you tried certain self-care strategies? So we'll definitely give you tips and techniques that you can provide to your colleagues as a method of helping them establish boundaries and to take care of themselves. But we also don't want you to feel like you need to be able to answer any situation. So if there are concerns that come up where the person is sharing that they may feel like they want to hurt themselves or hurt someone else, or they're at risk because of substance related issues. You know, we're not going to leave you in a place where you have to handle those kind of calls yourself. We'll have mechanisms and things into place, protocols in place, so that you know how to manage those high risk concerns. So because we're overseeing this program as CCA, you know, we're making sure that there is very similarly same type of supervision that we would offer to one of our clinicians. We want to make sure that you have some sort of protocols in place so that you're not having to find the substance abuse clinic and get that person treatment. We'll support you in making sure that you know what it is exactly you would do in those scenarios. So you'll have that. We're going to talk through that in the trainings. We are, you know, we want to make this as interactive and as engaging and to make you feel as comfortable as you can to be that support to your colleagues as we move forward. And it's going to be a challenging but really exciting program. And if anything, will bring some light to just the need for taking care of ourselves and our well-being through all of this.
Great. Thank you. And we'll talk about it further, but we will provide 24/7, 365 support. So that's, as Manendra was saying, we support all the peers. If there's any high risk situation, we'll step in as needed and take over, you know, do whatever needs to be done, and we'll help with referrals to any kind of specialty program or anything like that. So if there's something beyond this program, we expect there will be at least some. Then we'll help to get that set up. Great, next slide, please. So again, here's how we're going to support the coaches. We'll oversee the whole program. We will. The intake's going to go through CCA. It's really we're going to talk about it in a minute, but it's an email and phone number. There also will be a website, but that's still going to lead you to the email and phone number. There will be a hotline number just for an emergency. But otherwise, the prospective people, you know, the physicians who want help will contact us through email, hopefully, or phone. We will find one of you who's been trained as a peer coach who's available. We make the connection, and then, you know, provide the number to that physician, and you get connected from there. Then we follow up. We make sure it's going as it should. We help with any high-risk situations. We help with any referrals. So that's kind of a quick rundown of how it's going to work. Next slide, please. So just sort of walking you through it here. A physician calls, and again, the hotline number is available. We make sure the peer coach can take it, and then we follow up and just make sure it's all running like it should. That's I kind of repeated myself here a bit, sorry, but kind of the same thing as I just said. Next slide. Okay. Here's the slide that says when the training will be, and I'm going to give you my contact information next, and we will make this whole deck available to all of you. But just the basic criteria is we want licensed physicians who are licensed in Arizona. We are asking for a 1-year commitment, and there's 3 trainings, so 2.5 hours each, and then the commitment is 2 hours a week from there. It may be less than that. It really depends on need and how many peer coaches we have, but it won't be more than 2 hours a week in terms of a commitment. If you're interested, we'll do a brief screening call with you, just make sure you meet all the requirements. And then here's the 3 training times. So September 2nd, 16th, and 30th, 5:30 to 8 p.m. Everything is virtual. So if you're interested, you know, we'll get you all up to speed before those dates. It's a quick timeline though, so we are trying to get people quickly to sign up. After this, if we haven't answered all your questions, then you can just contact me. You'll see the email and phone number, and we'll try to answer any questions that you might have. So there you have the volunteer info. Okay, next slide, please. So here's the contact information. I'm overseeing it. I actually have a team of people. So anytime you send an email, it goes to 5 people, not just to 1. Same with if you call that number, it's a voicemail. It'll be distributed to a number of people. So if you want to volunteer or if you want to hear more, contact me, mdlounge@ccainc.com, and we'll set up a quick call. We'll get all your information, make sure that you're feeling comfortable with it. Oh, here's something I actually meant to say with the last slide. I already had somebody who was interested who said they couldn't make one of the dates. We're definitely going to have at least one make either full session or small group or something, but we'll make sure that there's some sort of extra session or follow-up. So if you can make 2 out of 3, that's pretty good. We can still work with you on that. If you can't make any of them, then it's going to be hard for us to get you trained, because it's just an important part of this process. But we'll definitely work with you and see if we can fit you in, regardless, if you are interested. So moving on, next slide, please. So here's just I'm not going to spend much time here, but here's just all the references. Again, I can share this whole deck with you if you like, where I pulled all the information in terms of substance abuse, suicide, depression, burnout, all that kind of stuff. It's all research-based. And the last slide, please. Okay, now we're available to answer any questions you might have. I appreciate your time and listening to me so far. But again, we're eager to answer questions and make sure that everybody is comfortable if they want to volunteer, that they know what it involves.
Great, thank you. Looks like we have a question here right off the bat. This may be addressed later, but will there be required contact between the physician and coach and ArMA or A&B, or is the coaching confidential between the coach and the coachee?
Yes, the answer is the coaching is confidential between the coaching client and the peer coach. We will know at CCA, who got referred, but anything, so that's not shared with ArMA or anyone else. That's kept confidentially at CCA. Only aggregate numbers would be shared. So ArMA would know how many people have used the program, not who has used it, and not any content about what has occurred. And that's by the way, our standard practice. We do that with all EAP. So I'm seeing on the chat that the MD Lounge at CCA Inc. doesn't work. Okay.
Yeah, I just tested it. It just bounced back. So I'm sure we have some technical things to work through, but
yeah.
I'm sure that can get worked out probably tomorrow.
Yeah, I tested it and it worked, but I haven't been testing it again. So here, what I'm going to do now is just put my email. And for the time being, people can just email me directly, and we'll see what we can do with that MD Lounge. Sorry about that. Again, it worked before, but I don't know why it's not working now.
All right, great. Thanks, Jay.
Great, thanks to you both. Next question on the list is, can you expand a little bit more on the weekly meetings? Is there structure? Is there a sequence of questions that are recommended to start off each week? Is it always one-on-one between a coach and another physician, or would there be a group situation?
Okay, so there is no, there's not necessarily weekly meetings. We're asking people to commit up to 2 hours per week, but it's not, the way it's going to play out is a peer makes contact, and then maybe that you'd see them again the next week, or maybe it'd be in 2 weeks or a month. It doesn't. So it's not going to be every week. There is no expectation to do groups, though, not with the peers. That's not anything we're setting up. Now we might do some informational webinars or support groups or something, but that would all be run through CCA. Maybe we would have a coach as a guest or something. But coaches are not going to be expected to run anything like that, any groups. It's all just one-on-one.
I guess a good way to kind of point this out, and I see this in the Q&A as well. Yes, in essence, you would be on call. If we get a call from a physician, we'll reach out to the people that we're still like to the peer coaches, see who has availability, and then you would just kind of set up some time from there. So yeah, I guess a good way to think of that is that you'll be on call 2 hours out of the week or something like that. But we'll share all of that in the training. And if we can speak to folks one-on-one, we'll give you a little bit more information around that.
And can you talk just a little bit about how that connection process will work? The peer participant will actually contact the number that's dedicated to our program or the department that's dedicated to our program at CCA, right? And then you'll connect them with the coach that's available?
That's correct. So what will happen is somebody will call, we'll get their information, do a brief intake with them, maybe on the phone, maybe just through email, depends what, how that comes to us. And then we'll say, okay, if we have enough information, we'll just connect them to a peer, or we'll call them and say, okay, what's going on? Tell me a little more. And then what kind of coach you're looking for? Do you have any preference, male or female, et cetera. And then and what times are you available, that kind of thing. And then we make the match. Looking down our list of peer coaches and knowing some information about them. And so we're just going to sort of manage that and make sure that we have the list. We call people. So what we would do, we would never give a referral to somebody calling that we hadn't already vetted. You know what I mean? We're not going to have them call a coach and the coach says, sorry, I don't have any time. We're going to make sure the coach knows in advance that, hey, we have a case here. Can you take it at some point in the next week, or they're looking for a certain time, you know what I mean? Something like that. And then we make the connection. And then we would give the number to the physician seeking help, and they would call the peer coach directly.
Thank you.
Great, thank you. Jay, I know we talked a little bit about this before we started tonight. You said you were comfortable with us sharing the PowerPoint presentation with all the registrations tonight? Okay, perfect. So that'll have the references in there as well to answer this question here. One of the other questions I see, and a quick reminder too, for anybody that does have questions or is looking to submit questions, please do it through the Q&A function rather than the chat. That would be it's easiest for us to be able to answer and make sure that we address as many questions as possible. I see Dr. Chetwal here has a question of how many coaches are you looking to recruit?
At this point, we're looking for 20. And it really depends. It's going to depend. We may not need 20 to start, but we're looking to train 20 now if we can. And then we'll really have to see on how the volume goes. So that's kind of the plan for now.
Especially because there's not a program that's like this by physicians to physicians. We want to make sure that we have enough to meet any potential demand. Although we hope that our Arizona physicians are very, very healthy and strong, we want to make sure that they have all the support that they can get.
Next question that came through the Q&A, are semi-retired physicians eligible to participate?
Yes, as peer coaches, or yes, and as, of course, as participants, absolutely. Semi-retired actually is a good resource for us because they may have more time, so absolutely.
Great. I have another question here. Does CCA operate in other states as well?
Yes. CCA is we're based in New York City, but we are national in terms of our client base, and we actually have a global reach. So we have some client companies that are big enough that have international employees. So we're nationwide. We have an affiliate network across the country and globally. So we're familiar with resources all over, and have a reach everywhere.
Great. Another question is, will coaches have to give out their personal contact information to the participant who they work with?
At this point, the answer to that is yes. So we're going to talk to you about boundary setting and so on, but yes, we're not planning to set up or use our system. We don't have a platform that people could communicate through.
Great. Another question here. Are people assigned to a certain coach the first time and then they stay with that coach throughout the year? Can you talk a little bit more about that process once they've been matched with an individual that is a coach?
Sure. So we're actually not thinking it's going to last a year. In a way, this program was modeled after other peer assistance programs and after how we do employee assistance program services. So that's short-term involvement. So we're thinking that we're thinking, you know, when I say short-term, I think 3 to 5 engage, you know, connections, that kind of thing. So we don't expect somebody to, but it may be a bit longer, you know, it depends, but this is not meant to be professional. This is not meant to be a long-term support. It's really in the moment, dealing with some stress, coming up with some tools, bouncing some things off of another individual, and then if they need additional help, getting hooked up with longer-term services. So it's in a way, it's kind of triage. That's kind of how I view it. But it doesn't have to be a major crisis. It could just be stress and wanting to connect with somebody. But we're not thinking it's really going to last a year. That's not a hard and fast rule, but I'm not thinking engagements are going to last that long,
Right.
Because if that were to happen, then our peer coaches would very quickly be taken up, and we would have no more capability. So that it's just sort of, it's kind of an EAP model. That's how we're viewing it.
Jay or Manendra, could you talk just a little bit about the difference between this and counseling? Because I know coaching is a more informal, it's peer-to-peer, but counseling or therapy or something like that would be a longer term ongoing. And I know you have resources and you can refer them to Arizona Resources, and we can refer them to various resources inside our health systems here if they want to or whatnot. But what's really the difference?
Jake, do you want to take that question? You want me to answer it?
Sure, go ahead. I mean.
So one of the things so this has brought up a lot of memories for me. I was sharing this with the team a few weeks ago, was that when I was in college, I worked at a peer support group. And so I got my first real introduction into that. And the key here is that it truly is one of those things that you're going to someone that's at your, you know, same sort of experience, right? Whether it's a student to a student, a doctor to a doctor, the idea here is that your shared experience, your shared background is the point, the common ground. And the difference to me is that as a therapist, I'm going to approach it from the lens of very much trying to understand sort of the root issues, trying to make sure this person's okay in the moment, but it's going to be a little bit more longer term, as you mentioned. And we're also trying to figure out if there's a diagnosis that we need to give to this person so that they can maybe be referred to a psychiatrist, or, like we've been saying, ongoing longer term treatment. As a peer support, it's those are the two key words, right? I'm a peer and I'm supporting this person in the moment. So very often it's going to be probably more like 1 to 3 sessions. This person had a really bad, stressful day and they really need to talk to someone about it. Or there's been multiple stressful days, as many of us have been experiencing, and they thought they were handling it well, but maybe they had a really bad fight with their partner, and their partner is just like, you need to go talk to someone. And so they pick up the phone and call you, because that's the person that they feel the most comfortable talking to. So to me, that's the key, is that I'm calling someone almost like a friend, but I don't know you, you're a stranger, so I feel a little bit more comfortable talking to you.
It's a listening ear of a peer who's been there, who can share some of your experiences, who can give you some of their insights of what they did. It's just someone who can listen. They're not giving professional advice. They're not evaluating you. You know, quite frankly, my bias with it, if you will, is I do hope that people who are reluctant to need help, who are reluctant to get it, will take this as a first step. You know, I envision that probably a majority will not need that. They'll just want someone to talk to. They talk a few times, they feel better, you know, fine. But somebody who really needs help but is reluctant to do so starts with this: oh, that was really helpful, great, okay, what do I do next? And they get walked to the next level of assistance, and then we help get them set up with something more open-ended.
Great, thank you. Jay, you mentioned in your answer to the last question about the time frame and what you anticipate the need is, and how you're not anticipating necessarily the full year, but can you or Manendra kind of elaborate a little bit on your experiences with such programs like the one we're looking to launch here? I know Juliana mentioned it's kind of a first of its kind for physicians, but is there any experiences that CCA has with other professionals out there for peer support programs, and that you might be able to elaborate on your experiences with those?
Can you, I can speak a little bit to it, maybe Manendra can as well.
Mm-hmm.
Some of the peer stuff I've done has really been more substance abuse related. And so all the people that came through it wanted professional help. And there really wasn't some of the same resistance. Well, I guess there is. That's why they're calling a peer versus just calling the EAP. But in a way, the peer coach would call us and we'd say, here's some resources, and sort of guide them. And then they would help get the person set up. So
Yeah.
the people that I was dealing with, for the most part, really were looking for assistance, but this was the entry point to it. So that's what I've seen. Manendra, you want to speak to it?
I think it varies. I think honestly, first year, certain people are going to try it out because they're very much in need. And as we've been kind of talking through today, is probably for the first time in history, there's been an increased focus on supporting people with their mental well-being in a way that's like genuine and destigmatizing. So if anything, a lot of the peer support programs that I've worked with in the past, they actually do continue. There are always ups and downs. The peer support program I ran in college is still there. And I will not say how long it's been, but it's been longer than a year for sure. But it really does kind of, it almost is a really great word of mouth resource. The more that people trust, the more that they see their colleagues that are struggling, they might actually then refer someone and say, I don't know if you know, and they may or may not choose to share their own story, but they're more than likely to say, I got some help and it's made a huge difference for me. I really think that you should reach out and talk to the peer support program. So that word of mouth piece is going to be very important. But we do see that it helps a lot. And it's just a great avenue to be that stepping stone for someone who's not sure about counseling, who maybe has been contemplating it and feels like, I don't know, because of all the reasons that we talked about before, especially confidentiality. I think this is a really great stepping stone for folks. So we actually hope it continues, and we fully expect it to continue. And if anything, some of the research that's coming out, they're anticipating, at least with nurses in particular, some of the research that I've seen and the work that we've been doing in that population program, is that they are expecting at least 10 to 20% of healthcare workers are going to start to experience even more severe mental health issues once the crisis starts to decrease, right? Because that's when we actually get to process what we just saw, what we dealt with. A lot of it right now has been, let's just deal with what's happening. And some of you, as the curve is coming down, you've probably noticed in the last couple of weeks that you're feeling more tired, you're feeling more drained, where you were very high energized. And so this would be the time we would want people to reach out and get re-energized again. That was a long-winded answer to the question.
No, it was great. It was really good. Next question we have is, how do you triage potential coaches to ensure that they're not sort of trying to work on their own issues while looking to support their colleagues?
Well, I have a conversation with them. So we're asking them, that's why we do some, a screening process. If they're not going to get counseling through us, you know what I mean? So if they're trying to work on their own issue, we ask them a bit of what's going on, anything stressful, but if somebody doesn't want to tell us, is a licensed physician, who meets all the other criteria, are we going to know? No, but I think they're going to find out quickly enough that this is not the route. If they need help, it doesn't make sense to volunteer to help somebody else necessarily. I actually do think there's a benefit for everybody to help other people, but if they have their own issue, it's going to come out, and we'll address that when it does. We ask about it, but we're not doing a background search. You know what I mean? We're not doing a in-depth psych testing or anything like that. So if somebody did have some issue that really, that was their main reason for doing it, no, we're not going to see it unless it comes out in a problematic behavior.
Right. One of the things we are going to incorporate into the training is just that. So we do have some content around psychological first aid and supporting yourself and understanding that, one of the things that we're trained in social work school and as clinicians is how do you set up those professional boundaries, right? Like how do you protect yourself from burning out? And so one of the things we do want to incorporate in there is that all of the advice we would be recommending that you give to your colleagues, we want you to be taking that yourself as well, right? So if you find that, maybe right now isn't the time for this because you are very stressed out and there's too much going on, then, totally understandable. And we appreciate the honesty there. But we are trying to build in some mechanisms where people will get some of that support for themselves through the training workshops. Especially, and that might be the point. This is also the other reason where we're looking for at least 20 people to participate through the training, is that people might find after going through the training that they might self-select out because they're realizing some of those things too.
Good.
Great. This is another question here. Some specialties as well as, ArMA, or there's physicians across the entire state that are involved in smaller types of communities. Are you going to try not to put a coach with a physician seeking the need together if they are the same specialty or work at the same hospital? Will there be any filters in place with your matching program?
Great question. That would be a question we would ask. In terms of specialty, people sometimes want another physician who is of the same specialty. So that's part of the intake is, what are you looking for? And probably I would not match somebody with somebody at the same hospital or institution though. So that is something we would be careful of. But otherwise, in terms of specialty, unless they, we would ask that. I mean, that's a good question. I hadn't really thought. I mean, I thought people would want that, but I think that's a fair enough question. Would you want somebody of the same specialty or not? So we can incorporate that in the intake.
And maybe the bigger part of that is the small community. They may or may not want to be working with someone who's at their same hospital or in their same small town.
Mm-hmm.
Yeah, it's unlikely we would even have someone to match that anyway. You know what I mean? So even if they did want it, we want someone in this community. It's like, we have 20 people across the state is what we're looking at. It's very unlikely we would be able to match a small community anyway.
Okay.
Great, thank you. Next question is, so if we, meaning the physician, want to recommend this resource to a physician, will there be information going out for those physicians to give to other people that they work with to recommend this resource?
Yes. It's going to be, it's not launching until October. So now we're just recruiting peer coaches and setting up the training. But it will be promoted, and there absolutely will be handouts, emails, whatever. We're going to want to get the word out. So yes, they'll be able to give that information to recommend it. Yes.
And I just want to remind everyone, this program is statewide. It is not dependent on ArMA membership. We definitely want to reach all the physicians that we can. So share.
Great.
I have one other question.
Yeah,
Jay and Manendra, we talked before about the program, including, all of the things that were in your slides, the burnout and those kinds of issues. And there's also other issues that have nothing to do with work, with patients that could be a problem. For example, a lot of our physicians are small employers. They're small businesses, and they're very worried about finances. They're very worried about their employees because they become very close when they work closely together. Are you going to have something in your coaching program to be able to walk people through things that are not, your traditional stressors?
Sure. I mean, in terms of the peer coaches, they're not meant to be giving advice ultimately, professional or otherwise. It's really more support. In terms of resources, that stuff we can flesh out further with you guys, with ArMA, in terms of what resources are available and how do we direct people. And if they wanted a referral, we could help, send them to financial counseling, if they wanted a coach, whatever, we could send them out to that. Yeah. So we could, in terms of a referral. So we know a lot of different resources for that. So
right. And we're going to, ArMA's going to supply a list of Arizona resources for you too. So
exactly.
So if my husband's just sick of listening to me vent at home, then I can call it. I need a friend.
Yeah. So yes, we can refer to any resource. Yes.
Okay, great. Thank you.
Some of them might be just, again, that listening ear, right? I've talked my husband's ear off and he's done, and he's like, go talk to someone else. So you're the person I'm talking to. From a stress perspective, I think it really is supportive to hear, these are the things that are stressing out. Maybe part of that could be relationship issues, and you might need a referral for marriage counseling or relationship counseling. And so that it really is, I think part of the role of the peer support is to know, my job is to listen, and then sometimes just purely say, look, you really need to talk to someone else about this, and here's a list of resources for you to reach out to.
Great, thank you.
Great. Well, thank you everyone for participating. This has been some great conversation tonight. I wanted to just go ahead and close out here with reminding everyone that tonight's town hall was recorded. It will be published on ArMA's YouTube channel for everyone to go back and review. Like me and Jay talked about earlier, I will be sending out the PowerPoint presentation that CCA has provided to everybody that registered for tonight's event. If you have any further questions or concerns about this particular program or anything else that ArMA can help with addressing, please do email us at communications@azmed.org. And then just a quick reminder as well for all the resources that are available to Arizona physicians on ArMA's website, including or around the topics of telemedicine, COVID-19. There's some FAQ on there, as well as some financial resources available to you. I'd like to thank Manendra and Jay both for joining us, as well as Dr. Goldberg and Juliana this evening. And we hope everyone has a great night. Thank you for joining us.
Thank you.
Thanks, everybody.
Thank you.
Bye.